fear of time, we'll probably just get going if people can take their seats. I'm Michael Gill, I'm the Director of the St James's CRF in Dublin. I'm very pleased to be here in Galway, and thank you to Declan and the colleagues for inviting me. So after this morning's introductory sessions, and even we got started into some statistics, we're now going to really get into heavy-duty statistics. I always thought randomisation was about tossing a coin, but we're going to hear a lot more of that now from our first speaker, who is Dr. Erika Daly. He's works with ICON and has been there since 2004, but involved in all sorts of aspects of their work, and is as I say, a full-blown proper statistician. I just noticed this morning that people were a little bit reluctant to ask questions, so I don't know whether you can involve the audience, or certainly please do. This is an educational thing, so please put up your hand if you don't understand something, or at the end if you have questions. Don't be afraid to ask questions. Okay, so...
Thank you for that, Michael. And yes, I second Michael's things. Please do ask questions. Otherwise, it's not very much about interaction and so forth. So, I'm going to be talking about methods of randomisation, and Frances touched on this in her previous presentation. But why do we randomise? As Frances highlighted, it's about avoiding bias in the allocation of subjects to treatment arms. It also allows us to maximise the statistical power of the trial by ensuring that the desired treatment allocation ratio is maintained, especially in subgroups or other smaller sections of the trial. It minimises the selection bias by not allowing the treatment to be predictable for the next person, which was what Frances was talking about, of that sense of checking the envelope and letting the next person in. But it also minimises the confounding or allocation bias, which is the male-female ratio, the age profiles and other baseline characteristics which could be confounded with the treatment effect at the end of the study. By randomising, we should be eliminating that. Or at least we should be making that any imbalance is only due to chance. We'll never get completely balanced groups, or at least it cannot guarantee completely balanced groups, but it does greatly reduce the possibility that imbalance will occur if we randomise. So a randomisation schedule is a list of treatment allocations of random numbers and treatments. It should be a schedule that is reproducible in case you ever need to go back and recreate it, and it should be kept securely so that nobody has access to it during the trial who shouldn't be able to see it. It needs to be generated with stable programming code, and this goes back to being reproducible. Excel has a random number function, but every time you do any cell change in Excel, all those random numbers change. So that's not stable. That'll be different every time you go to it. So you need to have something that you can fix and know that it will be performing as expected in a repeatable way each time. The seed is the number that starts our randomisation, and that determines the order in which the allocations are assigned. So that needs to be known, it needs to be retrievable, but it also needs to be blinded and kept separate from people who shouldn't have access to the treatment allocation during the trial and only revealed at the end. And then a copy of the list, both a hard copy and an electronic copy, should be stored in a controlled location until the unblinding occurs at the end of the trial. The reason I emphasise the need for the hard copy here, paper copy is really, really important, because I remember the panic we had on the day of unblinding, all ready to go, and the randomisation code came into us on a 3.5-inch floppy disk. None of us had a drive to read it, and there was panic of, well, how do we retrieve the codes? Because it had been a slightly longer running trial, and between the start and the end, the technology had changed. So having a paper copy means that you will always have a method to go back and refer to. And if you're trying to retrieve data off a source that maybe is slightly older, you have something that confirms that the file has not been corrupted, and you can confirm that's exactly what was intended in the trial. I'd also advise, when designing a randomisation schedule, you'll know from the sample size, which John will be talking about in a moment, how many subjects you need in the trial. That is not how many randomisation numbers you need in your schedule. Make it much bigger than the study design requires. It doesn't cost you anything extra to make the list 1,000 numbers instead of 100 numbers if you do it at the time. If you find during the course of the study that actually there's been a higher dropout rate, or for some other reason you need to randomise additional subjects, and you've only got the exact 100 patients that your original sample size suggested, and now you need 150, it can be very costly and time consuming to get one list for those extra 50 patients. As a general rule of thumb, I usually use 3 times the number of subjects required by the design to be the number of items in the list, plus a little bit to round up if you wish. At that rate, you're fairly secure that you're not going to need an additional list created. The schedule should contain a couple of basic things. The randomisation number, the treatment allocation, and this should usually be contained in 2 ways. A coded version, so treatment A, treatment B, or treatment 1, treatment 2, and then the decode of that, which is the exact name of your treatment. So that might be active and placebo, or treatment 583, 50 milligram dose, or whatever it is that you want to describe those treatment groups as. And then, depending on your design, you may also need to include a block number, stratification descriptions, which is either each stratification factor separately or in a kind of concatenated one-factor way, and we'll talk about stratification in a moment. And optionally, you may require a sequence number. Now this comes, and certain people request it, that the randomisation list is not sorted by the randomisation number, but instead all those numbers are jumbled up. Then you might want a sequence number so that you have an order in which the numbers appear that makes logical sense as opposed to a jumbled mess. What the schedule should not contain is any information about the subject numbers in the trial, because the linkage between the randomisation number and the subject number happens during the trial as you randomise patients, whereas the randomisation list is created before the trial starts as part of the trial design. So those 2 things are separate. So the first type of randomisation I'm going to talk about is simple randomisation. You have a list of random numbers, the corresponding treatment code, ARB, and the decode, and the treatment allocation is balanced across the full list. So in a list of 100 randomised subjects, 50 will be assigned treatment A, 50 will be assigned treatment B, if it's a 1-to-1 allocation. But it doesn't follow that in the first 10 patients, 5 of them will be A and 5 of them will be B. In fact, it could look like this. And in the first 11 patients, as you see there, you could have 10 Bs and only 1 A. This could be problematic if it's expected that there is a difference between the early and the late enrollers in your trial. For example, the early enrollers may be the people who have got very severe case of the disease, who are on the waiting list. As soon as this trial opens, I want to be randomised into it. And then as the time goes on and the recruitment period goes on, you're getting the milder cases who have to be convinced to join the trial. Or it could be because of different countries and different standards of care in those countries, enrolling at different times, or even centres, but countries is an extreme example. Poland, for example, the typical time for site activation is 6 months in Poland compared to about 4 months in other European countries. So if you think Polish patients are going to be different and they're going to be your late enrollers, that could cause a confounding issue for you. Another problematic version of the simple randomisation list is if there are DSMBs or interim analyses are planned, or if the study is stopped for any reason. You could find yourself with an imbalance on the first subset of the list. If you continued enrolment, it would eventually be corrected. But if you're looking at an earlier time point, you won't have that balance, and that may make it difficult to perform the comparison between the groups. So one way of getting around this is block randomisation, which ensures that the balance is maintained in the subsets. The treatment allocation is balanced within each blocks by maintaining the correct proportions within a block. So if it's a 1-to-1 ratio, you have an equal number of treatment A and treatment B. The choice of the block length, though, or the block size, depending on your terminology, is really, really important, because Well, firstly, how you choose it depends on the number of treatment arms you have. Generally, a multiple of the number of treatment arms is a good number to be the block size. But if it's too big or too long, you end up with really large blocks and the same problem as you had with simple randomisation, that a subset of that block could be unbalanced. And of course, if you have slow enrolment and not every block gets filled, you could have an issue overall in the trial. If it's too short, though, it could be predictable. If you have 2 treatment arms and a block size of 2, well, you know the first person got something, but you know the second person definitely got something different. Now, you may not know which way round that is, but you do know something about the drug effect of those 2 patients, and that is a partial unblinding of the trial and could lead to those patients needing to be withdrawn from the trial. So you have to find that balance between practicality and predictability. Generally speaking, a good rule of thumb is 2 to 3 times the number of treatment arms is a good size for the block, but it has to be a practical size. If you're doing a dose-finding study with 6 treatment arms, we're talking about a block size of 18, again, is too large, will lead to imbalance and has its own problems. Then, how to determine the total number of blocks for including the randomisation schedule, it is simply the total number of randomisation numbers you want divided by the block size. So if you have 100 subjects on your randomisation list and your block size is 4, you have 25 blocks. If you want a block size of 6 instead, well, you need to increase your randomisation list size to 102, so it's divisible by 6 and you'd have 17 blocks. So this is what it would look like. The block is included there, and you can see 2 Bs and 2 As in each block. There is this period where you have 3 As in a row, but that is because they're going across different blocks. It means that you can never have a long run. In this case, the longest run you could have would be 4 until you'd be back to the other treatment group. Stratified randomisation is another way of dealing with the problem of imbalance. You stratify your subjects by their baseline factors and then randomise within those strata. So baseline factors would be important prognostic factors, the age, sex, disease severity, which might promote more balanced allocation between these strata. So the levels of those known factors are included in the randomisation design. This particularly helps when you've got small sample sizes, because one patient out could be a big imbalance, so it may help in that design. Stratification, though, by more than 2 or 3 factors, rarely necessary. I know a lot of people say there's loads of things that they think are relevant, but if you start doing large numbers of stratification factors, it's less successful at achieving balance because you have too many strata to fill, and it's logistically really troublesome to deal with. So 2 to 3 is sufficient. But all of the stratification factors you include in your design, you then must include in your analysis. So you have to be aware, depending on the type of analysis you have, that these factors are suitable for inclusion and whether that affects your choice of stratification factor. An example is here on the next slide. So stratum 1 are males with moderate disease severity, and there are 100 patients in that group, 100 randomisation numbers in that group, probably far fewer patients required. Stratum 2 is the males with severe disease severity, stratum 3 females with moderate, etc. One thing I've done here, the start of the randomisation number is the stratum number. This isn't actually required in any sense. You pick whatever range for randomisation numbers you want when designing your randomisation schedule, but it does help from a practical point of view to have that linkage in it. It doesn't in any way unblind the study, because you know in advance what your stratification factors are. They're known prognostic factors subject to the baseline characteristics. It doesn't affect predictability, and so it doesn't bias the treatment allocation. It also means that if you do need additional randomisation numbers at some future point, you can easily link them in with kind of a logical place without having to, start the next set of randomisation numbers at the bottom of the female severe group. You're going back to having moderate males because you've got kind of spare numbers that you can slot them into. If lots of stratification factors are really important, we can look at dynamic randomisation. It's also known as adaptive randomisation, and it is basically about having algorithms that assess the values for subjects already randomised in the trial and uses that to adjust the probabilities of which treatment group the next patient will be allocated to. So there's two ways you can assess the values in the trial. You can either look at the covariate profile of the subjects you have, or look at some measure of their response to the drugs and treatments that they've been receiving. So if you have a lot of factors, as we said, the number of strata becomes very large very quickly, prohibitively so. Minimization is a technique of covariate adaptive randomization, which looks at all the specified covariates collectively, calculates the imbalance by assigning this new patient to this treatment group, sums up over all the covariates, to this treatment group, sums it up, and gets an overall imbalanced score, and then assigns that person to this treatment arm that minimizes the overall imbalance for the study. It can be useful when there are a large number of factors that are thought to influence the treatment response, which you feel that the simple randomization won't distinguish between your groups sufficiently for. The other form is the response adaptive randomization, or outcome adaptive randomization, or continuous response modelling. It goes by various names. And this looks at the response to treatment, either the primary endpoint or some sort of surrogate measure of the endpoint. And it increases the probability of being assigned to a treatment arm if previous people in that arm have shown favourable trial results. It can be useful when you're modelling, say, a dose-response curve. You might have a large number of doses, and this quickly eliminates the high doses that are untolerated and the low doses that are ineffective, and gets people on the main part of the curve where we really want to study things. But it requires a response that has a really short time compared to the recruitment rate, because obviously the longer it takes to get your response measure, your subjects will already be recruited without the benefit of that knowledge to adapt the algorithm. PK data, such as the maximum concentration of the drug or the time to that maximum concentration, are often used, therefore, in these dynamic randomizations. But finally, the success of any dynamic allocation scheme depends entirely on the quality of the algorithm chosen to affect and adjust the probabilities of the subjects into each treatment arm. And it also depends on the quality of the implementation of that algorithm. So you might have a wonderful algorithm that you found in a paper, but a really badly coded one because you didn't have access to the original coding. A great algorithm, poorly coded, is useless. So the complexity and logistics of the potential impact on the analysis should be carefully evaluated if you want to consider dynamic allocation. So going on to another topic, which is about balancing, and Frances touched on this in her presentation. ICH E9, which is Statistical Principles for Clinical Trials, recommends that you should be stratifying by centre, or equivalently that you be assigning groups of blocks to each centre, which is balancing by site. This effectively divides the randomisation list into distinct parts. Each centre has a part of the randomisation list and can operate independently of other centres. So to illustrate it, assume these are the first 5 subjects we have in the trial, and they're at 3 sites, X, Y, and Z. The notation is there. And taking the blocked randomisation schedule we had before. So the first subject into the trial was at site X, so they get the first randomisation in the first block, block 1. The second subject into the trial was from block Y, was from site Y, so they need a new block, so they get the first number in block 2, which is 1005. The third subject was also in site Y, so they're also in block 2. Fourth subject, we need a new block, they get block 3, and then back to block 1 for the fifth subject. So there are gaps in the assignment list. Randomisation number 1003 hasn't been used, even though higher randomisation numbers have been used. You can also see that in the first 5 subjects in this trial, 4 of them have been assigned to treatment group A and only 1 has been assigned to treatment group B, even though this is a blocked randomisation, which would imply that in the first 4 subjects you should have 2 A's and 2 B's. Because we are splitting people across blocks, it doesn't happen. So if you have a large number of sites with few subjects per site, so you have a lot of incompletely filled blocks, you can introduce a level of imbalance even with a blocked randomisation. Central balancing is what Francis was mentioning, which is that if we have the technological advances that we have had in the last 15 years, we can now actually balance across the whole study centrally, and that is feasible. So that's called balancing by study or balancing centrally. So subjects are assigned to the next available randomisation number, regardless of which site they're coming from, and therefore the corresponding treatment arm with that randomisation number. So as you can see, they just go in order, and in the first 4 subjects we do have that benefit of blocking the equal distribution. But it requires a system that can centrally monitor the randomisation at all sites and ensure that the correct randomisation number is assigned each time. And it also impacts on how treatment kits are labelled and distributed to the subjects at each site. At this point, I'm going to deviate slightly from randomisation and talk about more of the practical implications. Stratification at each site, as we've discussed, can mean that many treatment kits are left over at the end of each trial. But you may not have time to get the right number of kits in, just say, right, well, you're coming in to be randomised today, so I'll only bring in your medication yesterday. Not always possible. It could be very costly to do that level of thing. It also just may not be feasible. So you have to think about what are the practical constraints on the method of randomisation you're using as well. Having a separate pack list or treatment list for labelling the treatment kits now, or pack list, can offer more flexibility in the drug allocation. The kits are not pre-assigned to any particular randomisation number or subject, so that unused kits can be reused by other people, or not reused, reassigned to other people. When treatment arms are made from combinations of dose levels, kits can be matched as needed. So if your active is 2 doses, and then your mid dose is 1 active, 1 placebo, and your placebo is 2 doses of the placebo, but it allows you to say, right, well, I've got 3 placebo on my shelf and 3 active on my shelf. So I can have 1 of each, or I can have 3 of the middle, or I can have some other combination, and you're not tied into only this selection is possible. And for multi-centre trials, unused drug supply at one site may be able to be returned to a central depot and then redistributed to other sites for use in the trial. This potentially is useful if you've got a large multi-centre trial and some sites aren't actually recruiting patients and you just want to close them, but you've given them 15 boxes of kit, and now you're saying, they've taken all my kit, I have to let them recruit because otherwise that treatment is wasted. But in this way you can reuse it in the sites that are actually performing and not lose out on that medication. So it's particularly useful in trials where there's low drug availability and therefore you have a constraint about how much resupply you can do. You have this option of a little bit more flexibility. So to create that pack list is the exact same as the randomisation schedule and subject to the same security constraints. But the schedule is a little bit shorter. It only needs a kit number and the treatment allocation variables. There's no need for stratification or blocking because that's all about the subject, and this is only about labelling kits. And kit number allocated then are recorded on the drug dispensing log or the exposure page of the CRF so that you have a record of what each subject received. Typically, you do need more kit numbers than you have subjects or randomisation numbers. So if you have a dosing regime for a 16-week trial and you're dosed at week 0, week 4, week 8, week 12, and you get a bottle at each of those visits, well, that bottle is a kit. So you have 4 kits per person and 120 subjects in your trial, so that's 480 kits you're going to need. But therefore, on your list, multiply that by your magical multiplier of 3, and you get 144 kit numbers needed on the list. But on the randomisation list, you only need 360, 120 times 3, so it's a huge difference in the numbers, and you have to be aware of that. There have been several pack lists that didn't quite work because the numbers were based on the number of subjects and not on the number of kits accounting for the dosing schedule. Ideally, just logistically, you don't have to, but it's a good practical thing to do. Use completely different numbers for the kit numbers and the randomisation numbers. So kit numbers are 5 digits beginning with 8. Randomisation numbers are 4 digits beginning with 1. That way you can't run the risk of somebody's randomisation number also looking like a kit number and giving them something that looks like their randomisation number instead of the kit number they were meant to get can get confusing. A lot of numbers does. So making them very distinct just makes it easier at site that mistakes don't happen. So we've mentioned before, analysis must follow the design. So if you're using a stratified randomisation, all the stratification factors must be included in the analysis. So for example, if you want to adjust for continuous covariate in your analysis, say age, but you have stratified by this in randomisation, say over under 65 was one of your stratification factors, then you cannot adjust for continuous age in your final analysis because you'll have both the continuous and dichotomous variant of age, which will be too highly correlated, and you can only pick one of them. And the one you have to pick is the one that was part of your design, which is your dichotomized one. So then something you really wanted in your analysis can't be there because of your design. So it's important that you think about how these two things will link together. Of course, covariates that aren't in the design can be in the analysis. It's only a one-way street of necessity. So it's worthwhile considering these factors that you think might be useful. Do they really need to be stratification factors, or are they things that we can just look at the analysis stage? At the unblinding stage then, when we're recovering the treatment allocation of the trial, we take the randomisation list and the PAC list with the clinical database and merge them together to get the treatment allocations. So we merge by the randomisation number to get the planned treatment. We merge by the kit number to get the actual treatment. And these are different because, going back to the intent to treat principle, anything about efficacy should be analysed according to the planned treatment. But if you're trying to assess safety effects, that should be concerned on what they actually took. So you have two different treatment allocations, and they can be different in the case that a mistake has been made or some misallocation of treatment happened during your trial. And therefore it's important to specify upfront how you will handle if somebody has been misallocated, which treatment group they're handling, especially if it's 1 out of 4 doses was the wrong dose. What do we do with that? So it's important to think about that in advance. It helps if you create a dummy list to practice the unblinding beforehand. It means that when it comes to unblinding, when you're in a rush to get to the final results of your trial, your programming is in place and you just have to press run on your computer and you'll get your results quickly. The dummy list will be the exact same structure as your live list by using the program, the reproducible program that we spoke about before, but with a known seed, say number 1, and that's your seed. And you get a list that's exactly the structure you want that you can use to practice, to get all your coding done for your analysis and for your unblinding. And then the live list would use the exact same program, but just change the seed, and that bit would be what would be kept securely until the trial ends. When speaking about unblinding, we have to mention emergency unblinding. So if the blind needs to be broken during the trial for safety concerns for an individual subject, we need someone who has 24 access to the codes, but who holds the codes for a multi-centre trial. And does the code holder have the necessary language skills to support a multinational trial? So if you have a central randomisation system, like an IVRS interactive voice response system, which is the telephone system Francis mentioned, or the more, I suppose, 21st century version of that, which is the web-based equivalent, it can be used to unblind individual subjects as your emergency unblinding method. Otherwise, code break envelopes can be a paper-based option, either held at each site or at a central location, but again, you do need to work out the access system for those. Importantly, don't use a full list of unblinding subjects as a way of emergency unblinding. Once a subject is unblinded to the conductors of the trial, that subject needs to be removed, and at that point, you don't want to accidentally remove any other subjects by unblinding them unnecessarily. So in summary, keep it simple. Minimise the number of stratification factors included in the randomisation and only use dynamic algorithms if there's a clear benefit or need for your study design. Beware of the practical constraints as well as the scientific objectives. Think about whether you want to balance centrally or by site. Do you have the infrastructure available to balance centrally, but is balancing by site suitable for your trial design? Remember that the analysis must follow the design, so consider this when choosing stratification factors and other randomisation design features. And finally, consult a statistician. It's better to do it at the start and make sure you're doing it the right way round than find out at the end that it's, Francis gave many examples of where it hasn't been applied properly and you're desperately trying to retrieve what's already been lost. So, thank you very much.